Hello and welcome back to the Oncology Brothers podcast. I'm Rahul Gosain here with my older brother, Rohit Gosain. Today, our focus is going to be on diffuse large B-cell lymphoma. As you're aware, diffuse large B-cell lymphoma is one of the most aggressive cancers that we run into, but it is potentially curable in the right settings with the right treatment. To better appreciate the current landscape and all that is happening in this disease side, I am excited to welcome Dr. Carla Casulo, one of the co-founders and co-chairs of a global organization, Women in Lymphoma, and a practicing hematologist here at my home institution, the Wilmot Cancer Center in Rochester, New York. Carla, thank you so much for joining us.
Thank you for the invitation. I'm excited to be here.
Perfect. Let's get started, Carla. Well, welcome. Diffuse large B-cell lymphoma, as Rahul stated, is certainly an important topic because it's an aggressive disease, but also it is one of the most common types of non-Hodgkin's lymphoma that we see, and we see fair share in community oncology as well. For years, the treatment has been R-CHOP or EPOCH. Lately, we've had some exciting approvals going from Polatuzumab or few CAR-T options and, of course, BiTE therapy as well. We have a lot to cover here. Before we jump into treatment options available to our patients, it is important to touch on some of the important topics, how to even biopsy or get the diagnosis. Carla, if you could touch on core needle biopsy versus excisional biopsy to make the right diagnosis, and also different types of diffuse large B-cell from ABC type versus GCB type, please.
Sure, those are important questions. So I think that whenever possible, you should try to get an excisional biopsy. And the reason is that if you think about a core biopsy, it is a very small sliver of tissue. If you look at your biopsy reports and you read the size of the specimens, are usually half a centimeter. And if you think about all of the different immunostains that need to be done on a very small sample, it makes it challenging sometimes to run these kind of high level, more sophisticated analyses, like, for example, FISH testing to look at double hit lymphoma, cell of origin, which sometimes helps to guide our therapy selection or at least think about the disease. And so I think that whenever possible, and if it can be done safely, an excisional biopsy is really important, because sometimes with a bigger sample, you capture other things in the background, like concurrent follicular lymphoma and like a transformation setting, for example, or other things like a T-cell rich large B-cell. I think it's especially the case if someone has a mediastinal mass. With a core biopsy, you can get a lot of necrosis and it makes the biopsies uninterpretable. So ideally, excision whenever possible and can be done safely.
And then you've touched on cell of origin because that ends up being important in guiding our therapy. Carla, do you mind touching a little on this and why is that important today?
Sure. So what we know about the way that large cell lymphoma develops is that the cell of origin, where it comes from within the lymph node, has some implications on sort of some of the pathways that are activated or not. So when you think about germinal center B cell or GCB type, that means that it has kind of follicular type features. It has a kind of a biologic program that stems from the germinal center. And the activated B cell type is anything that's kind of in the surrounding area outside the germinal center. That's probably the easiest way to think about it. But a lot of these classifications were developed based on gene expression profiling, which we know is not available routinely. So we have to rely on kind of surrogates for that, which would be using immunostains. So CD10 is a marker of the germinal center, for example. So when you're looking at your biopsy, you see CD10. Almost always it's germinal center, but not exclusively. Your pathology report should say whether it's germinal center or non-germinal center. But bearing in mind that non-germinal center is actually a couple of other subtypes. Non-germinal center just means the activated B cell type, non-ABC type, there's still other things that can be encompassed within that. But what we know is that it's the programming pathways that drive the lymphoma that are kind of embedded within that classification. So that's kind of why we make it a point to look at the cell of origin.
Perfect. Thank you for that foundation. So now you have an excisional biopsy confirming that we're dealing with large B-cell lymphoma. Carla, do you get bone marrow biopsy in all your patients as part of your workup?
Not anymore. So really PET scans have shown that there's a lot of utility that PET scans can pick up on bone marrow involvement, so we're not routinely doing them anymore. If someone has pancytopenia and you're worried that there's another concomitant problem like myelodysplastic syndrome or something else, I think it's not unreasonable to get one, and I certainly have many, many times. But I feel like now studies suggest that you can get away with looking at the PET scan for as a surrogate for bone marrow involvement, so you probably don't need it.
Perfect. Okay, so with that in mind, let's start off with a patient being stage 1 or 2 disease, where the disease is confined to one side of the diaphragm. Carla, can you walk us through your initial approach to your first-line treatment in this setting?
Sure. So it so happens that here at Wilmot, we have a clinical trial for this scenario. But what we know about stage 1 and 2 large cell lymphoma, there have been lots of studies. You probably are familiar with them, looking at, longer versions of chemotherapy versus combined modality therapy. And in general, whenever you use combined modality therapy, you are extending progression-free survival a little bit, but there's really no gain in overall survival. So recent data is suggesting that probably if you use 3 or 4 cycles of chemotherapy and the patient is PET negative at the conclusion of therapy, you may not need additional radiotherapy. Now, remember that that's in someone who's non-bulky. If someone has bulky disease, there is still a tendency to want to consolidate them with radiation. And I too fluctuate between radiation or not for someone with bulky disease that's PET negative. But I think that you probably can safely, if they're PET negative and you believe that it's a good quality PET scan, Doble 1, 2, or 3, remember, we really want to use that Lugano criteria whenever possible. That's super important. I think you probably can safely feel confident that the data supports chemotherapy alone in someone's PET negative. There's some SWOG studies that have looked at that, British Columbia Cancer Agency studies looking at that, and other international studies. So I think that would be a reasonable approach. So yes, so I'm looking here, R-CHOP versus R-POLA-CHOP. So if you look at the POLARIX study that looked at R-POLA CHP versus R-CHOP, that study actually included untreated diffuse large B-cell lymphoma. So about 10% of patients on that trial had limited stage disease. So I think you could confidently feel that if the person has an IPI of 2 or higher, which is really the label for Polatuzumab, you could feel safe and confident that that is a reasonable strategy, bearing in mind that there's slightly higher rates of febrile neutropenia with Polatuzumab, so you have to, take that into consideration. But it would be absolutely appropriate to use R-CHOP for what if you use it. You can also use a PET adapted approach, right? If you feel comfortable doing that, R-CHOP, and then if the PET is completely negative, doing 1 additional cycle of R-CHOP for a total of 4. Again, if you're looking at nuances of a PET adapted strategy, you might want to just call one of us and just say, does this make sense? Because that could be a little tricky, the nuances and the field, right? So for limited stage, you want it to be within a certain field. As an example, I had a patient recently who had limited stage lymphoma, but it was kind of in the mediastinum. And so sometimes that's tougher because mediastinal lymphoma sometimes is treated differently, often is treated differently. This patient also had a prior remote breast cancer history. So I think you need to think about those things in context too. Kind of a long answer to that, but I feel like there's a lot of important nuances here. So I wanted to make sure to touch on them.
Now, you also talked about the point of Polatuzumab. In our clinic, where we have stage 1 or stage 2, where based on high risk score as per IPI, would you use Polatuzumab versus R-CHOP in these patients? We will talk about this in stage 3 and stage 4 setting as well, though.
I think it's appropriate to think about our Polatuzumab. Again, if the IPI is 2 or higher, again, that's the label. And the patients included on POLARIX had limited stage disease also. I think that that's very appropriate to use 4 cycles of our POLA CHP without radiation, again, in non-bulky, limited stage, large cell lymphoma. It's an appropriate strategy, I think, in my opinion. R-CHOP is also completely appropriate too. And I think we'll probably talk a little bit about the controversy of cell of origin. But at our institution, I think we're not uniquely using cell of origin as a mechanism to drive lymphoma management for in this situation. That recognizing that is a moving target, and that will likely evolve over the next several months. But at least as of right now, a lot of the studies are very compelling, but suggesting that there's a differential benefit in the activated B cell type. But I think where we are in 2024, July, it's reasonable to incorporate ARPOLA for IPI 2 or higher for limited stage.
Thanks.
Carla, thanks for touching on that. I'm actually just going to use this as a segue to even talk about stage 3 or stage 4, because we'll keep bringing POLARIX. And the reason to bring that up here is what you've mentioned. The cell of origin ends up being important. Younger patients or patients with low IPI in the POLARIX trial did not have clear benefit. So out in the community, when we're even dealing with stage 3 or 4, can you walk us through your treatment paradigm? And right now you've mentioned you're using Polatuzumab in all your patients. Is that your expectation for us out in the community as well?
I think not for all patients. If their IPI is 2 or higher, I think that ARPOLA CHP makes a difference. There is a progression-free survival benefit. But you're right, there are a lot of findings that are suggesting that the larger benefit is kind of being diluted because of no benefit in germinal center B tumors. So I think that if you're out in the community and you have a new diagnosis of large cell lymphoma and this patient has an IPI of 1, technically they don't meet the labeled indication for Polatuzumab. So I would say that in this case, using that IPI score is helpful because it could tell you how to approach treating in the absence of a clinical trial, for example, right? But if someone has an IPI of 2 or higher, then I think it's absolutely appropriate and important to offer that if the patient is someone who you think could tolerate the heightened risk of infection potentially. I think it's appropriate, and that's something that we do. So again, though, as time goes on, and in 6 months, if we meet again on this topic, I suspect that there will be more data evolving on this. So at ASH, I suspect that some data will be reported on further investigation of the cell of origin, because remember that those were subgroup analyses on the POLARIX. They weren't powered to detect a difference in those populations. So it's very interesting and extremely exciting to learn about how that is going to be a very, like a prognostic and a predictive biomarker of response, not just prognostic, but a predictive biomarker. And we have very few of those, unfortunately, in large cell lymphoma. That would be a phenomenal scenario to be in. And we probably are moving in that direction. But at least as of right now, I don't know that we could, in the community setting without knowing how the cell of origin, how faithful is it? It's only an 80% concordance rate. So I think you have to be a little careful without more data, at least right now.
Absolutely.
Well, more to come on that and how to see the treatment options will entail based on cell of origin. But so far, what we have discussed is patients in good performance status and good cardiac function. Can you touch on a few options that you utilize if the patients are rather frail or compromised ejection fraction here?
Right. So that's not an uncommon scenario. You have a very much older patient or someone who's in poor health. I think that, with someone with a poor ejection fraction, there could be an opportunity potentially to use mini CHOP dosing, so 50% anthracycline dosing, depending on the extent to which the cardiac function is poor and whether it's something like, for example, is someone on goal-directed medical therapy? Is this a reversible cardiomyopathy? I've had situations where I work closely with cardio-oncology or a great cardiologist that happens to be familiar with, some of these toxicities, and partnering with them and saying, look, this patient's on GDMT. It looks like they have recovered a lot of their ejection fraction. They're optimized. They've been in good health for the last year. Occasionally we would still use an anthracycline for someone if their EF is, let's say, at the border, maybe 45%, maybe, or 48%. And then they're followed very closely with serial echoes. You have to have a robust system in place to be able to do that comfortably. But I think if someone is truly with a cardiomyopathy where anthracyclines are contraindicated, then I like the options that you have here. So our go-to typically is either RCEOP, which is the etoposide containing regimen, or RCGVP, which is the gemcitabine containing regimen. I tend to use the gemcitabine containing because it's a little easier. It's day 1 and day 8. The etoposide is 3 days in a row. You could use the intravenous etoposide, and sometimes people use oral etoposide, which I find a lot harder to give. So I would favor the GCVP, but that's more of a preference. I don't know that, obviously they haven't been compared head to head,
Right.
so we can't say one is better than the other, but we know that they've both been tested in that population safely.
Thank you for covering that, Carla. So we know that majority of our patients usually have good response in first-line treatment. But with that said, about 30 to 40% of our patients will still have relapse or refractory disease. Carla, there's a lot happening in this space with new CAR T approvals. We also have TAFA-LEN, TAFA being an anti-CD19 antibody. We also have BiTE therapy. Can you walk us through this busy space here, your treatment algorithm for relapse or refractory diffuse large B-cell lymphoma?
Yeah, you have a great algorithm here. So I think, as you noted, if they've relapsed within 12 months, then the approved products would be axi-cell or lyso-cell. As you know, CAR T-cell therapy is a highly complex treatment to give. And I think the most important message is to refer early. Because let's say I see them, and then we need to initiate some type of bridging therapy. So the selection of bridging is important because we know that certain treatments at second line will affect CAR T mobilization, like bendamustine, for example. It affects CAR T cell fitness. So you want to be really thoughtful about what second line bridging therapy you pick, right? After that, once they then start the process of meeting with our CAR T program, there is insurance authorization that needs to take place. There's all these other things that need to be taken into consideration: caregiver support, proximity to the cancer center, inability to drive for a period of time after CAR T. And so all of those things are really important. And then someone in a rural area that drives 3 hours to come here who has limited support, I think that would be a heavy lift for someone. So those are some of the things that we think about when thinking about second line therapy. Now, let's say someone has relapsed. Wait, before I go into that, that said, obviously CAR T is an incredibly important tool and has saved the lives of so many patients that otherwise had a very poor prognosis. So don't eliminate someone from CAR T consideration on the basis of the social component, but it's a consideration that you need to think of, over time. And then for someone who has relapsed later, there is still potentially a role, particularly late relapses. There may particularly be a role for salvage chemotherapy and transplant, like the traditional auto transplant. But remember that the response rates to salvage are only about 50%. So you're still kind of missing the opportunity to salvage another, half of those patients that may not get to CR and go to auto. Those patients can subsequently go to CAR T cell therapy third line. But I think, they're a little bit more beat up by then. And then some of the other choices you have here, like Polatuzumab BR, great for someone who you don't think is going to be a CAR T cell candidate, maybe has already seen a bispecific, not unreasonable. Again, tafasitamab, lenalidomide, a great combination. This is a space where there's a lot of interest of how to sequence treatments and what makes sense for what person. I feel like a lot of these have good response rates. And then liso-cell is for someone who may be ineligible for autologous transplant, or maybe, had a late relapse, or for an older patient because it has slightly less toxicity. And then the bispecific question, again, a super exciting space. Both epcoritamab and glofitamab, two excellent choices as bispecifics. And, for patients, I think the selection of one over another is more kind of nuanced, right? So for glofitamab, it's fixed duration treatment. It's given every 3 weeks. There is a ramp up to it. There's a ramp up dosing to all of these bispecifics. And then one of the things with glofitamab is that you have to give patients obinutuzumab first, which is an anti-CD20 antibody. And the reason for that is to mitigate the risk of cytokine release syndrome. So they're getting the obinutuzumab first, and then a week later they're starting the glofitamab. So they're not completely at a therapeutic, target immediately, as you might think. Like, you give somebody chemotherapy and you expect it to work right away. So you do have to wait a little bit, and then there is a step up with dosing. So that's one consideration. That said, limited duration of treatment, and for patients in CR, they could have very durable rates of CR. So that's actually really exciting. Epcoritamab is slightly different. It's as of now, indefinite therapy until toxicity or disease progression. There is a lot of steroid that's used with epcoritamab in terms of just for mitigating CRS and mitigating some side effects. It's subcutaneous, though, really easy to give. But because of the high steroids, you have to think about prophylaxis against pneumocystis and viral. So that's another consideration. Among the other ones that you have here, Lonca-T is another great option. Response rates are lower though, and you have to think about edema with Lonca-T and some hypersensitivity like skin rashes and things like that, which we see.
And if one has progressed less than 12 months and they are not eligible for CAR T or they can't travel for CAR T, what are the treatment options that you rely on in those circumstances?
So I think that bispecifics are really second line or after second line. So if you can get it, that would be great.
Okay.
But if you can't, then I think it sort of depends on what you think the sequencing might be. So if you anticipate that at some point you're going to refer this patient to, maybe they're not eligible for CAR T now, but maybe they might be at some later date. You may want to limit the bendamustine. Maybe tafasitamab lenalidomide is a reasonable choice. I think that it's a fairly effective regimen. I think that you have to just grapple with the cytopenias and be comfortable managing the cytopenias. And then, like I said, occasionally you are able to get some of these other drugs second line if you petition the insurance companies, recognizing that that's not really the standard.
Right.
But yeah, I think Polatuzumab or TAFA-LEN are very reasonable options here.
We can certainly talk and be excited about these treatment options unless we know how to manage the toxicities, it's rather hard to sort of utilize them. So if you don't mind touching base on very superficially in terms of the toxicity profile of the CAR T and other treatment regimens that we just talked about from BITE and Lonca and selinexor.
So for the CAR T, I think the things that you'll see the most often when the patient comes back to you will be cytopenias. It's not uncommon to see cytopenias lasting quite some time, particularly the T cell subsets. So we measure T cell subsets by flow cytometry, we measure CD4 counts, and we have to continue prophylaxis until their CD4 count is greater than 200 for pneumocystis. And then we do continue antiviral prophylaxis. That said, even despite that, some patients will still have reactivation of certain infections. And unfortunately, among the causes of death for CAR T patients in the post-CAR T setting is infection. Non-lymphoma related death is largely due to infection. So I think it's important to bear that in mind. The other thing is hypogammaglobulinemia. We see that a lot. And some institutions will kind of mandate prophylaxis with IVIG or supplementation with IVIG if their IG level is less than 400. I think that's probably a safe strategy. Sometimes we do it when it's even less than 600. Our cutoff in our lab is around six-ish, mid-sixes, because if someone is having infections and they're mildly hypogammaglobulinemic, I think you can justify that. So I think those are the two most important things. There are certainly later toxicities, like generally these patients are very heavily pretreated, so you're going to see some MDS at some point probably. That's not, out of the question. So looking at those late toxicities in terms of cytopenias, most importantly infections, and then watching out for second cancers. With regards to the POLA-BR, I think with that, you also can see some T cell depletion with bendamustine, and you could see infections in that setting. I've seen that quite a lot, as well as the neuropathy with Polatuzumab. So that's another consideration. TAFA-LEN, I think that, again, primarily cytopenias.
Action.
I've not seen a lot more in terms of, the standard lenalidomide related side effects like diarrhea, rash, those things are not uncommon, but I think that the cytopenias can be limiting, and then that can be abrogated. And then some with the bispecifics, like I mentioned earlier, at the risk of cytokine release syndrome, fever, hypotension, that kind of prodrome of symptoms. And then the neurotoxicity that you've read about with CAR T is really not observed to the same extent or severity in bispecifics. And so I don't think you should worry too much about that, although they've been reported about 6%, 10% at the most. Very rarely do you see neurotoxicity. And then Lonca-T, like I mentioned, risk of rash, photosensitivity, and then edema. So I've seen that quite a bit. And again, I've not used selinexor yet, so I can't really speak to that one. But those are the most common ones that we see.
Well, thank you so much for summarizing that. One can actually go on quite a bit on this topic, but thank you so much for putting this out for us and covering the landscape of diffuse large B-cell lymphoma, what we have today. For our listeners, stay tuned as we recap the key points from today's discussion.
Today with Dr. Carla Casulo from Wilmot Cancer Institute, we had a chance to explore the current treatment landscape for diffuse large B-cell lymphoma, covering everything from initial diagnoses to the latest advancements in this therapy. In first-line settings, we've seen approval of Polatuzumab based off POLARIX trial. Are you using Polatuzumab in all your patients upfront or only selectively in ABC type?
We've also discussed the treatment landscape beyond first line, where now we have few more options available to us: CAR-T, BiTEs, and anti-CD19 antibody agents. Each of these agents have associated side effect profile, which is very much unique to them. And it is critical for us in the community to get more comfortable in managing some of these side effects. Thank you for tuning in. Stay up to date with us on the latest in oncology. We are the Oncology Brothers.